Welcome everyone to another Canadian League Against Epilepsy, Canadian Epilepsy Teaching Network monthly rounds. Today I have the pleasure of introducing a dear friend and colleague, Dr. Puneet Jain. Dr. Jain is a staff neurologist at SickKids and assistant professor of pediatrics at the University of Toronto. He obtained his initial medical training in pediatrics and pediatric neurology from various prestigious institutes in India. And then he came to SickKids to do an epilepsy fellowship. His clinical interests are in the medical management of children with medically refractory epilepsy, epilepsy surgery evaluation, cortical mapping, VNS, and epileptic encephalopathy with spike wave activation in sleep, as well as infantile spasms. His research interests mirror his clinical work, and he has authored more than 180 papers in multiple peer-reviewed medical journals and has been very prolific both clinically and on a research basis. So it's an absolute pleasure to have Puneet here today to be speaking about his experience with vagal nerve stimulation in pediatric epilepsy. And the next 45 minutes or so are yours, Puneet. Thanks again for joining us.
Good afternoon, everyone. Thanks so much, Robin, for a very kind introduction. And thanks to the CLAE and the CETN team for this very kind invitation. So today what I'm going to do is provide an overview of VNS therapy in pediatric epilepsy. I do not have any relevant disclosures relevant to this talk. So what I'm planning to do in next 40-50 minutes is briefly go through the anatomical and physiological basis of VNS, review some of the available published efficacy and safety data. If time allows, go briefly through the fundamentals of VNS programming, and on the way also discuss the place of VNS in the broader treatment algorithm for pediatric DRE. So after a lot of canine experiments in 1980s, the first human VNS was implanted in 1988. And after some landmark randomized controlled trials in 1990s, the VNS was first approved for use in adults for focal epilepsy in Europe in 1994, followed by approval by FDA in US in 1997. In 2001, the indication for VNS expanded, and now it included depression as well. And more recently, in 2017, FDA approved VNS for pediatric use, but again for children aged more than 4 years, again only for focal epilepsy. Now, like your iPhones, VNS device has also undergone significant changes over the last 2 to 3 decades of being in practice. The initial device, NCP M100, was launched in 1997. And since then, around 5 generations of device have been released by the company. And currently in North America, what we are using is the Sentiva M1000 device. Sentiva M1000 retains the closed-loop neurostimulation feature and program scheduling of the Aspire device. And in addition, it has better communication speeds and also additional day-night programming as one of its additional features with this new device. So who are the good candidates for VNS? So patients with drug-resistant epilepsy. As per FDA, the approved age is more than 4 years of age, but it has been very frequently used off-label for even younger kids. And at SickKids, probably the youngest patient we have implanted is close to 2 years of age. Epilepsy can be both focal or generalized. Again, in pediatric age group, it's more commonly the multifocal or generalized epilepsy who are the usual substrates for VNS therapy. But again, that uses off-label as FDA approves VNS only for drug-resistant focal epilepsy. Important to note that before implanting VNS, make sure the patient is not eligible for more potentially curative surgical resections or disconnections. And if there is a comorbid severe mood disorder like depression or suicidality, then obviously VNS trumps over other palliative surgeries like TBS or RNS. Who are not good candidates? Patients with significant sleep disorders, especially ones with obstructive sleep apnea, which we'll talk later in more details. Any patient with significant cardiac rhythm abnormalities, or if there's a poor access to healthcare facilities, because these patients post-implant do require very close follow-up. But again, having said that, these are more relative contraindications and are not absolute contraindications for a VNS implant. So first, I'll very briefly discuss the anatomical and physiological basis. We know that vagus nerve is one of the longest cranial nerves in the body. It has more than 25,000 nerve fibers, and most of its fibers are unmyelinated. So the ratio of unmyelinated to myelinated fibers in VNS is around 2:1. The afferent fibers, meaning the fibers which are going towards the brain or carrying signals towards the brain, they are again predominant, constituting more than 80% of total fibers. Now, these tons of nerve fibers are usually arranged in these bundles or fasciculi in humans. And at the level of cervical vagus nerve, it is estimated that there are 5 to 8 fascicles which are present at the level of the neck. Uh, More recent research has shown that there seems to be a spatial separation between afferents and efferents. So these larger myelinated nerve fibers, which are mainly visceromotor, they occupy positions more peripherally. And the more numerous afferent fibers, which are more tinier, some of them are myelinated, some of them are not, they occupy a more central position. Vagus nerve has different kinds of nerve fibers, like any other nerve. But from a VNS perspective, it is important to know that VNS causes preferential activation of A alpha and A beta fibers. So these are large myelinated fibers which have lower activation threshold. But obviously, it's not a very selective stimulation. It does stimulate other kinds of nerve fibers which are present in the vagus nerve. And some of them are responsible with some of the side effects that we see with vagus nerve. For example, the A alpha somatomotor fibers, which innervate the muscles of larynx and pharynx, can lead to some of the gagging and obstructive sleep apnea that we observe in some of the patients post VNS. A delta fibers, they innervate the pulmonary stretch receptors. So this one mediates the side effects of cough or bradypnea, which are again seen in some patients with VNS. And these tinier, smaller, myelinated sympathetic or parasympathetic fibers, which can potentially be cardioinhibitory in patients post VNS. The mechanism of action of VNS is not very clear. However, in recent years, a concept of vagus afferent network has emerged. So we know that this vagus nerve, it projects to this nucleus called nucleus of tractus solitarius in the brainstem. And from here, it then has multiple subcortical and cortical connections. I think the two most important nuclei that one must be aware of is locus coeruleus. Locus coeruleus is the primary site of noradrenergic neurons in the brain. And we know that noradrenergic signaling is an important mediator of the anti-seizure effect of VNS. The second important system it regulates is the serotonergic system, and VNS modulates this networks through the dorsal raphe nucleus. So noradrenergic network and serotonergic network are the two most important networks which is modulated by the VNS. It also modulates the thalamocortical connectivity through parabrachial nucleus. It induces plasticity and increases functional connectivity in the limbic system as well. And it also tends to have a strong anti-inflammatory effect through its actions on the hypothalamus. So overall, all these structures constitute what is now called as vagus afferent network. And probably this is the neural substrate which mediates the anti-seizure effect of VNS. Now, VNS device basically broadly has two components. One is the electrode contact and one is the implantable pulse generator. This lead has 3 electrode contacts. One is the cathode, one is the anode, and third is the anchor. And the implantable pulse generator is usually implanted on the left side of the chest where it stimulates the left vagus nerve. In cases where there are surgical or anatomical constraints on the left side, in those cases, sometimes right-sided VNS implantation is offered. How does right vagus nerve differ from left vagus nerve broadly? In heart, the main target of right vagus nerve is the sinoatrial node. And theoretically, there is a risk of causing significant bradycardia, especially based on rabbit experiments. On the other hand, left vagus nerve, the main target in the heart is the AV node, and potentially it can have an effect on AV conduction, which is very rare in clinical practice. Further, the superior cardiac branch on the right side also tends to have a bigger parasympathetic innervation, again leading to higher theoretical risk of bradycardia with the right-sided vagus nerve stimulation. So in general, in clinical practice, usually left vagus nerve is implanted for VNS purposes. Let's review some of the data which is available regarding its effectiveness. A lot of initial data came from the landmark randomized controlled trials, which were done in early 1990s. In these trials, adults with drug-resistant focal epilepsy were randomized into two groups, one group with high-level stimulation. Here, the parameters actually approximate the parameters we currently use in our clinical practice. And the other group was a low stimulation group, where the frequencies were 1 to 2 hertz, so very low frequency, almost acted like a placebo. So in these trials, the important outcome they saw was the responder rate. So we'll hear a lot about this responder rate during this talk. So responder rate means percentage of patients who experience more than 50% seizure reduction at that particular time point as compared to baseline. So in these trials, the responder rate varied between 20 to 30% in the high-level stimulation group. There was another smaller pediatric randomized control trial which came in 2012 from Netherlands. Here, only 41 children were randomized, and here the responder rate was even lower than the adult trials. It was close to 16%. So besides these sparse randomized control trials, especially in the 1990s, there's also a lot of observational studies which are available, which have explored the effectiveness of VNS in pediatric epilepsy. So a few years back, we did this systematic review and meta-analysis, and we included a total of 101 studies in this review. And when we calculated the pooled prevalence estimate, the 50% responder rate was around 56.4%, and the seizure freedom was seen in around 11.6% based on results from these 101 studies. So that's why in clinical practice, what we counsel the patients before VNS is this 50-50 rule, where we say that 50% patients will have 50% reduction in their seizures post-VNS, a more realistic expectation, and only a very small fraction of them will actually become seizure-free post-VNS. This review also showed that early VNS therapy is better in terms of seizure outcomes. So patients who had shorter duration of epilepsy and were tried on lesser number of anti-seizure medications before VNS implant, these are the patients who showed higher responder rate at 1 year in this review. Also, when we looked at the seizure freedom rates, the seizure freedom rates decreased with the increasing number of anti-seizure medications that were tried prior to the time of implantation. So again, highlighting that earlier the VNS therapy is offered in appropriate patients, there's a possibility of better seizure outcomes versus a more late implantation. Now, if we look at specific etiology-specific outcomes, we've recently published this study. One of our amazing epilepsy fellows, she looked at seizure outcomes in patients with monogenic DEEs and malformations of cortical outcomes and compared them how they did on VNS. So in this study, what she found was the responder rate in monogenic DEEs, which is blue in this graph, and in malformations of cortical development, which is green in this graph. The malformations of cortical development had slightly higher responder rate, but this was not significantly different from the monogenic DEEs. When Dravet syndrome was a big chunk of these monogenic DEEs, 12 out of 44 patients had Dravet syndrome, and the responder rate in Dravet syndrome, which is shown in orange bars here, also did not significantly differ from the responder rates achieved from other monogenic epilepsies or even these structural causes. We also looked at our tuberous sclerosis data, and here the responder rate with VNS was around 45% in our patients. And when we compared this, sorry, there's an ongoing announcement now.
Code blue resuscitation dialysis unit, 6th floor main hospital. Code blue resuscitation main hospital, 6th floor dialysis unit.
Sorry for the interruption. The patients with TS experienced a responder rate of 45% with VNS, and this was not very significantly different from patients of TS who had tried ketogenic diet. Only important difference was patients with ketogenic diet did achieve 11% of them achieve seizure freedom as compared to none in the VNS group. And in the literature, the pooled responder rate in patients with TSC, according to one systematic review, was 68%, which was obviously higher than our institutional experience. Seizure type specific data is very sparse in VNS literature. As far as GTCs are concerned, they are one of the most disabling seizure types in this patient population. And some of the new data comes from the core VNS database, which is a multi-center database across 60 centers across the world. Here, they identified 115 patients who were experiencing generalized tonic-clonic seizures at the time of VNS implant. 50% of them were pediatric population, but the median age at VNS implant was around 18 years. They saw a 74% reduction in the frequency of GTCs at 1 year post-implant, and this slightly increased to 77% at 2 years. So significant decline in the GTCs frequency. If you look at the seizure freedom rates from GTCs, this was 37% at 1 year and 42.6% at 2 years. So significant decline in number of GTCs with VNS, and a significant chunk of them did become seizure-free from this disabling seizure type. Some data also exists for atonic seizures. So this meta-analysis was published a few years back by our neurosurgery colleagues. At that time, 4 studies were available for VNS for atonic seizures and had around 116 patients. In this review, they found seizure freedom rates in approximately around 20% patients, and the responder rate was seen in 61.2% patients. When they compared this with corpus callosotomy for atonic seizures, the seizure freedom rates were obviously much higher for corpus callosotomy, to the tune of 50 to 60%. And when they calculated the pooled effect size, again, it was very strongly in favor of corpus callosotomy. So in short, corpus callosotomy obviously is a better palliative surgery for atonic seizures, especially patients who are having frequent injuries, as compared to VNS. But VNS does lead to some meaningful improvements if corpus callosotomy is not possible due to whatever reasons. People have also used these two therapies in sequence. So in this study of 127 children with Lennox-Gastaut syndrome, they explored the added efficacy of a corpus callosotomy. So these patients had VNS at 7 years of age, and after VNS, they experienced 21% of them had more than 50% reduction in their drop attacks. Subsequently, these patients underwent corpus callosotomy at 11 years of age, and after that, 83% further patients had 50% seizure reduction. In the reverse scenario, patients who already had corpus callosotomy and subsequently went on to get VNS, in these patients, around 53.9% patients had further 50% seizure reduction, and this slightly dropped to 41.7% at 2 years. So definitely some signal of additive effect of these two palliative therapies. If we look at the broader epilepsy syndrome of Lennox-Gastaut syndrome, so what literature do we have here? So this systematic review we again published last year, and we included 37 studies here in this review with more than 1,000 patients on VNS. The pooled 50% responder rate was around 50.6% in this review. Interestingly, we also calculated the responder rate in patients with Lennox-Gastaut syndrome who got DBS and RNS. And in these patients, the pooled responder rate was much higher. So with DBS, it was 69.7%. And with central median RNS, this was around 63%. But again, to note that these figures are based on smaller number of studies and also smaller number of patients. So just 27 or 81 patients versus more than 1,000 patients in the VNS group. Therefore, these estimates did have a wider confidence interval. So some cautious interpretation of these results. So basically, we do not know who will respond to VNS. The responder rate seems to be similar in different etiologies with different seizure types. So people have studied various clinical variables, EEG markers, MRI findings, even systemic biomarkers, including inflammatory cytokines, but none of them have proven to be a good biomarker of VNS responsiveness. In more recent years, some of the network-based connectivity biomarkers have shown a more promise and also robustness to identify VNS responders. And hopefully in near future, these will move from bench to bedside and will be integrated in our clinical workflow. Now, does VNS have a role in super-refractory status epilepticus in ICU patients? I found this systematic review, which was just published last year. They were able to find 64 patients from 17 studies, and 61% of these patients were pediatric. The mean age at VNS implant in this population was 17.3 years, so slightly older patient population. 21 of these patients had a diagnosis of NORS, and the mean duration of status prior to VNS was pretty long, so 81.5 days in this review. So based on author's interpretation, the VNS response was classified as responders in a big chunk of patients, so 51 out of 61 evaluated. But obviously, in such observational studies, to attribute the entire seizure reduction to VNS is tricky because a lot of co-interventions obviously are going on in ICU in these complex patients. So to circumvent that limitation, there was another study which was published last year. Here, they took 60 children with FIRES. 30 patients got VNS and 30 patients did not get VNS. The mean age at implant of VNS in 30 patients was 7.2 years, and the mean duration of status was 19.4 days in these patients. And most of them had tried at least 4 immunosuppressive therapies and ketogenic diet, which is the usual scenario in this complex patient population. The mean VNS parameters at the time of ICU exit were 2.45 milliampere of output current and 27% of duty cycle. So what they found that 70% patients who got VNS showed status termination within 14 days of receiving the implant. The duration of status was also higher in controls. So patients who did not get VNS had 19.5 days of status versus 12.7 days of status post VNS. And interestingly, mortality was also higher in patients who did not get VNS. So 33% patients in those controls and 10% patients in patients who got VNS. So pretty significant response to VNS in this patient population. They also published their rapid uptitration of VNS settings in this ICU setting. So they went from an output current of 0.2 milliamp to an output current of more than 3 milliamp in a matter of 14 days. They subsequently also optimized the pulse width and duty cycle after 7th to 8th day of implantation. And this rapid uptitration was mostly well tolerated and did result in meaningful responses in terms of seizure reduction in this patient population. So something to be explored or considered in patients in FIRES who have failed multiple therapeutic strategies. What about long-term follow-up? This is one of the most widely quoted studies in VNS literature, published way back in 2011. This study included 65 patients, and approximately 1/3 of them were children. The mean age at implant was around 30 years, and what they showed that the seizure reduction gradually increased over time. So it was around 40% at 6 months, and this figure gradually increased to nearly 80% at the end of 10 years. And the mean seizure reduction in last follow-up in this cohort was 76.3%. Again, these results need to be cautiously interpreted. In observational studies spanning over a decade, multiple other factors obviously come into play, like natural history of epilepsy, multiple other co-interventions that these children undergo even after implantation of VNS. Now, obviously, there's some degree of bias from observer expectations. Contradictory to these results, the data comes from our center, where we showed that early response to VNS actually predicts the long-term outcome instead of the small incremental increase in outcome over years. So in this study, 209 children were included with at least 12 months of follow-up. The mean age at VNS implant was 11.8 years. 65.6% patients experienced some benefit with VNS within 6 months. And the 50% responder rate at last follow-up, which was close to 3 years, was 58.4%, which is close to the literature responder rate. But what this study showed that the patients who experience early benefit to VNS in terms of seizures, they are the ones which are likely to exhibit favorable treatment response at every time point studied. So, for example, if a patient is classified as responder at 6 months, he will probably continue to be in this category at even 1 year and 3 years. And a patient who is a non-responder already at 6 months, it's a very low probability that he'll suddenly become a responder at 3 years. So patients tend to remain in their same category, and early response to VNS probably is a more better predictor of their long-term VNS response. Now, another frequent question that families usually ask, will my child be off anti-seizure medications if he or she is implanted with VNS? So some nice data comes from Korean Health Insurance Review and Assessment Services. So in this study, more than 6,000 pediatric patients were included, and they were divided into three groups: medications alone, epilepsy surgery, and the VNS group. So in the epilepsy surgery group, you see a gradual increase in number of ASMs prior to the point of epilepsy surgery. And in 1 to 2 years post-surgery, there's a dramatic decline in the number of ASM use, and subsequently they plateau off. In case of VNS, again, a similar story. You see a gradual increase in number of ASMs prior to the time of VNS implantation. And after that, that continued increase in ASM requirement is blunted, and there is probably stabilization of ASM use post-VNS. They also looked at the ASM discontinuation rates in their cohort, which obviously, as expected, was highest in epilepsy surgery group. Around 32.4% were able to discontinue after around 4 to 5 years of the procedure. In VNS, this was lowest at only 8.8%. So this is what we tell our families, that VNS primarily stabilizes your ASM use, but it's very low probability that patient will be able to come off anti-seizure medications completely. So something to remember. Now, improved quality of life has also been seen in patients who have undergone VNS. This beautiful prospective pediatric data comes from the Connectivos database, which is led by Dr. Ibrahim Slavet Sikkits. And here, our team showed that there was significant increase in the QALC scores, which is a measure of quality of life. There was significant increase at the end of 2 years, and patients who experienced clinically meaningful improvement was around 37.1% at the end of 2 years. Another interesting data which came out from this study was this improvement in quality of life was more related with changes in improvements in seizure severity and also improvements in sliding seizure timescales. By this, I mean that patients who go from daily to weekly seizures or weekly to monthly seizures, they are the ones who are more likely to experience any improvements in quality of life. The 50% responder rate, which is very commonly used outcome points for VNS studies and other therapies, this was not correlating with improvements in quality of life. Obviously, a patient who is having 100 seizures in a day, if he or she goes down to 50 seizures in a day, it's very unlikely that there will be a significant improvement in his or her quality of life. There is also limited evidence to suggest that VNS therapy may be cost-effective therapy for DRE, and this is mainly probably related to reduced healthcare-related costs following implants. Another study which was published in 2022, which was from US Healthcare Claims Database, they actually showed that epilepsy admissions and epilepsy-related ED visits, these epilepsy-related costs were 55% lower post-VNS implantation, especially when compared with patients who were receiving RNS or DBS. Again, the reasons for this better performance for VNS versus other neuromodulation devices was not elaborated in this paper. An overall mortality benefit is also observed with VNS, obviously due to better seizure control, so reduced SUDEP risk, reduced risk of injuries and other comorbidities. So in this study from, again, Pediatric Health Information System from US, they showed that patients with post-epilepsy surgery obviously showed the maximum survival or mortality benefit post the procedure. Patients with continued medical therapy, which is in red and red worm in this figure, they showed the least mortality benefit, and VNS patients were somewhere in between. So the probability of surviving beyond 10 years post-VNS was around 92.6% versus 98.45% for the epilepsy surgery cohort. And as I said, this overall mortality benefit obviously includes a reduced long-term SUDEP risk post-VNS implant. Now, these are complex patients, and often besides VNS, they end up getting other palliative surgeries like corpus callosotomy or other neuromodulation device. So does VNS have any synergistic or additive effects? Now, with corpus callosotomy, already we saw some studies with atonic seizures where VNS can have additive or synergistic effect with corpus callosotomy. And in more recent years, there is emerging data about DBS and RNS, where again, it is clear that when used together with VNS, they may have some additive effect. Regarding DBS, the data comes from the advanced trial, again led by Dr. Ibrahim's team at SickKids. Here, we included 18 children. So these children had drug-resistant epilepsy, and they were deemed non-responders to VNS after 1 year of optimization. These patients were then randomized into continued VNS therapy or as an add-on DBS. So what this trial showed that patients who got add-on DBS, they experienced 51.9% further reduction in their seizures post-DBS as compared to only 12.3% reduction in patients who continued to be on VNS optimization. So definitely add-on DBS does seem to work or provide additional benefit in these patients who seem to be not responding to VNS fully after 1 to 2 years and should be considered early once patient has failed VNS. So these were all surgeries. What about Cenomate? I think all neurologists in the audience and me too are very excited about this new medication, Cenomate. How does this interact with VNS? Now, we know that Cenomate has established efficacy, especially in highly refractory patients that we see in our clinic, especially patients with DEEs. So this review was again published earlier this year, and they looked at efficacy of Cenomate in highly refractory DEEs. Here, the 50% responder rate was around 56.8%, and a significant chunk of these patients actually became seizure-free on Cenomate. Cenomate has also been used in patients post-VNS. So this is mainly an adult data. So here, 52 adult patients were started on Cenomate post-VNS implant once they had partial response or ineffectiveness of VNS. And after 10 months of Cenomate, here the responder rate was further 44.4% patients had more than 50% reduction in their seizures on Cenomate, and 11.1% of them experienced seizure freedom once Cenomate was started, once VNS had failed. So big question is, can Cenomate defer VNS? This question was explored in a smaller study, which was again recently published. Here they included 23 adult patients who were waiting for their VNS, were there on their waiting list. And these patients were trialed on Cenomate. And after 3 years on Cenomate, around 18 of the 23 patients that they enrolled had more than 50% reduction in their seizures, although no one was seizure-free. But interestingly, 13 out of these 18 patients decided to defer VNS, though they were not seizure-free, but their seizures were definitely much better on starting Cenomate. So some signal that Cenomate really works well in these super refractory cases. So based on limited evidence and mainly expert opinions, there have been few recommendations made in this regard. So this recommendation comes from 2024 from experts from US and Europe. So what they recommend that Cenomate should be tried before phase 2 evaluation, especially for suboptimal surgical candidates, which we frequently see in our SAG cohort. Definitely Cenomate should be tried before going towards palliative neuromodulation strategies like VNS, RNS, or DBS. And trial of Cenomate is also reasonable while waiting for pre-surgical evaluations. So something to be considered before going towards these palliative therapies. Now, we briefly touched about right-sided VNS. We said that it's usually offered to patients when there are surgical or anatomical constraints on the left side. And theoretically, there's obviously a higher risk of bradycardia with right-sided VNS. But what's the real-world experience? So this study was published recently, and they were able to accumulate 38 cases from across the world, although a lot of cases came from Europe. Here, the mean age of right-sided implant was 28 years, and almost 1/4 of these patients had Lennox-Gastaut syndrome. Most of these patients have had left-sided VNS, so 34 out of 38 had left-sided VNS prior to right-sided implant, and the delay between left and right-sided implants was close to 9 years. The various reasons for implanting right-sided VNS in this cohort was infection of the previous left-sided implant, or various anatomical or surgical constraints on the left side. So what do they find? In this study from 38 cases, the responder rate was 55.3%, which is very close to what we see with left-sided VNS. The mean reduction in seizure frequency was 56.2%. And it was found that right-sided VNS was more efficient than the left-sided VNS in 2 patients. It was less efficient in 1 patient, and the rest of the cases, the efficacy was more or less similar. So in terms of effectiveness, the right-sided VNS almost performed at par with the left-sided VNS. Now, what about safety? In most of these patients, so 30 out of 38 patients tended to tolerate right-sided VNS very well. 1 patient was reported to have stimulation-induced bradycardia, which was managed by lowering the output current, and subsequently he tolerated the right-sided VNS well. 2 of these patients developed first-degree AV block, and again these patients were managed conservatively, and they continued to be on right-sided VNS with no further complications. So again, from a safety perspective as well, it seems to be pretty well tolerated. Obviously, it requires more careful, cautious cardiac monitoring post-implant. What about transcutaneous VNS? So it's obviously a less invasive form of VNS, and multiple targets have been used, but most commonly stimulated site is the ear. Ear has an interesting cutaneous innervation. A big chunk of ear is innervated by the greater auricular nerve, smaller rim through the auriculotemporal nerve, which is a branch of cranial nerve 5. And this area is the one which is innervated by the auricular branch of the vagus nerve. So this is the area of Simba and Concha. So auricular VNS basically stimulates this area. It's like a earphone, and it basically stimulates these 2 kind of areas in the ear. Theoretically, again, this branch of the auricular branch of vagus nerve, it tends to have 5 to 6 times less of A beta fibers as compared to cervical vagus nerve. And if you remember from the earlier slides, these are the most important fibers which are required to carry the signal from the vagus nerve to the brain. So theoretically, it should work less effectively. But what do we have from clinical perspective? So this systematic review was published now a few years back, and this included 10 studies with more than 300 patients, both adult and pediatric. This included 3 randomized controlled trials. Where data was available, 5 used bilateral ear stimulation and 3 used unilateral ear stimulation. As opposed to VNS, this is more of an intermittent stimulation where people use 3 to 4 sessions in a day, ranging from 1 to 4 hours per session. So in terms of effectiveness, what they found was the mean seizure frequency reduction was around 30 to 65% post-auricular VNS. And the responder rate mean was around 43.4%, but it ranged between 5 to 100%. So again, not bad as compared to 50-55% that we see with more invasive cervical VNS. Some studies also reported improvements in seizure severity and quality of life. From a safety perspective, it was mostly tolerated well. So in general, based on this very limited literature, it seems to be working as well as the invasive VNS, but theoretically, since this nerve has less afferent fibers, it may have limited effectiveness, but our institute doesn't have any personal experience, so we are not using it for the time being. Now, we talked about effectiveness in great details. Let's move on to the other side of the coin, the safety. So in general, VNS is a very well-tolerated therapy. Most side effects are mild and they tend to diminish over time. The common ones that we experience include hoarseness of voice, cough, paresthesias, or shortness of breath. The more relatively rare side effects include infections or hemorrhage at implantation site. Sometimes the lead may fracture or malfunction. And more rare side effects include vocal cord paresis, lower facial weakness, or sometimes even bradycardia and asystole has been reported in occasional case reports. This is one of our patients who developed a small hematoma following a VNS implant. This was managed conservatively, and in 2 to 3 weeks, this resolved and the the wounds also healed well, and he continues to do well on VNS. Just an example. Another important side effect that has been reported in more recent literature is the obstructive sleep apnea. And there is both pediatric and adult literature to show that in predisposed patients, many of them have higher rates of obstructive sleep apnea, and also something called apnea hyperapnea index, which is a measure of the severity of OSA. This also tends to be higher in patients post VNS implant. We recently published our experience in this regard. So in this study, we included 27 patients. The mean age at VNS implant was around 9.1 years. At baseline, so a sleep study was done before the VNS implant. Around 6 patients were diagnosed to have obstructive sleep apnea. 5 had mild obstructive sleep apnea, and 1 had moderate obstructive sleep apnea. The median obstructive AHI was around 0.84 per hour, so around less than 1 event of apnea or hypopnea in 1 hour. We repeated the sleep study after a mean latency of 7 months in these patients. And in these 7 months, the median VNS parameters were 1.5 milliamp of output current and 10% of duty cycle. And when we repeated these sleep study after 7 months, now 11 patients had obstructive sleep apnea, so 41% from 6. 8 were mild, 1 was moderate, and 2 had severe obstructive sleep apnea. 9 children were the ones who showed some worsening of obstructive sleep apnea, but most of them went from having no obstructive sleep apnea to mild obstructive sleep apnea, though there were few outliers who went from severe to more severe obstructive sleep apnea. The median obstructive apnea hypopnea index also significantly increased from 0.84 per hour to 1.59 per hour. And for children who are less than 13 years of age, 2 events per hour is the cutoff for diagnosis of mild OSA. So still smaller, but a significant increase from the pre-VNS stage. So definitely some worsening of OSA post-VNS implant on smaller settings, but most of them ended up developing mild OSA, not requiring any aggressive treatment for that. So this is one of the examples of sleep epochs from one of our patients on VNS. So this is a 13-year-old girl with Rett syndrome. The VNS settings at this time point was 2.25 milliamp of output current and 36% of duty cycle. This channel shows the stimulation, the VNS activation with these orange rectangles. This channel flow here shows the amount of airflow at the level of nostrils. And these are chest and abdominal bells, which measure the chest and abdominal movements with respiration. So you can clearly see that in this patient, every time with VNS activation, there's a significant decline of airflow at the level of nostrils, with more milder decline at chest and abdominal movements. So this was very classical of VNS event-related obstructive hypopnea event. And when we calculated the obstructive apnea hypopnea index for this patient, it was around 24.3 per hour, which qualified her as a moderate OSA patient. Interestingly, despite being Rett syndrome, this patient did not show any evidence of central sleep apnea in this sleep study. So what are the possible mechanisms? As I had hinted previously, VNS is a non-specific stimulation, so it also stimulates your A-alpha visceromotor fibers. These also supply your vocal cords, and overactivation of these efferents can lead to fixed vocal cord adduction. And this probably explains the emergence of obstructive sleep apnea in some of these patients. These are representative figures from something called drug-induced sleep endoscopy, where it's showing open vocal cords when there's no VNS stimulation on. And as soon as the VNS is switched on, there is strong vocal cord adduction, almost leading to a glottic collapse, probably contributing to obstructive sleep apnea in this patient. Very rarely, VNS is also associated with central sleep apnea, and this has been postulated to be due to some sort of cortical desynchronization, but it's rare in patients post-VNS. So how do we manage these patients? It's a multidisciplinary approach. Obviously, we rule out the anatomical factors. The easy ones there are adenoids and tonsils. If they are enlarged, obviously those surgeries help with management of OSA. In general, the mild OSA, even if it develops post VNS, is managed conservatively. Some pediatricians do use intranasal steroids, but then it ends up, to evaluate the risks and benefits of continuing VNS therapy. What is the morbidity of drug-resistant epilepsy, and what is the morbidity of obstructive sleep apnea? If the VNS parameters needs to be adjusted, the various strategies that we use here is reducing the on time, reducing the frequency. If it's 30 hertz, make it 25 hertz or 20 hertz. Now with the Centiver model, we can also use day-night programming so that we can have lower settings at night, especially if the patient doesn't seize much at night. We can reduce the output current, which we usually do it at the end. And in more extreme cases, VNS can be discontinued if OSA is really getting very severe. While we are making these VNS adjustments, obviously our respiratory colleagues support the patient with various kinds of respiratory supports. So something to be aware and something to be vigilant about in more susceptible patients, more complex patients who get VNS. Another important safety issue with VNS is the MRI safety. This should be obviously true for other neuromodulation devices like RNS and DBS as well. Now, as far as VNS is concerned, when we are using only the local transmit receive coil, which is usually used to scan head and hands and feet, in those cases, the area of exclusion for MRI, so you cannot scan in this area. It ranges from C7 to T8. When we are using body coils, which is a no local transmit receive coil, the area of exclusion for MRI is larger. It extends from C7 to L3. In these cases, even the scan time is restricted, so usually less than 15 minutes in a 30-minute window. With VNS, you can use both 1.5 or 3 Tesla magnet strengths, although there are restrictions, especially with RNS, where we can only use 1.5 Tesla for scanning. So for MRI, pre-MRI, the VNS is usually turned off. So all the output current, the magnet current and autostim current is made zero. And the detection for the autostimulation mode is also switched off. And once MRI is done, the VNS is switched back on with the baseline VNS settings. So something to be aware of, something to be flagged in the patient charts. Otherwise, it can definitely lead to a safety hazard for patients with these neuromodulation devices. I don't think I would have time for going through the VNS programming, so maybe I'll skip to the last few slides. So what do we do with these complex patients with drug-resistant epilepsy? So any patient with drug-resistant epilepsy needs to be referred to a tertiary care epilepsy surgery care center where a detailed epilepsy phenotyping is required. Based on that evaluation, patient may require further investigations, whether it's phase 1 only or phase 1 and phase 2 evaluations. And then based on this clinical evaluation and investigations and type of epilepsy, then further steps are decided. So if the patient has generalized epilepsy and is drug resistant, if the drop attacks are the predominant phenotypes with a lot of injuries, especially in more mobile patients, then obviously corpus callosotomy is the most effective palliative surgery which can be offered to these patients. But if not, then in general, most centers will start with ketogenic diet as it's a less invasive strategy. But if ketogenic diet, the patient is not eligible or has failed ketogenic diet, then in general, VNS becomes your treatment of choice after this stage. Now, if patient has partial response to VNS or VNS is ineffective, then based on parental preference and also institutional experience or preference, options like centromedian DBS or centromedian RNS can be offered. If it's a focal epilepsy, obviously the more curative resection or disconnections surgery should be explored first. But if these are not possible due to whatever reasons, then VNS always remains a backup option here. If it's a more frontotemporal network and based on institutional experience, ANT-DBS is an option. And if intracranial recordings are desired, especially let's say in case of bilateral temporal epilepsies or the ictal onset zone is very close to eloquence, then RNS may be an option in these patients. So what do we do at SickKids for the VNS workflow? Usually the patient gets evaluated by the pediatric neurologist or epileptologist. And if they think VNS is an option, they'll refer the patient to the VNS clinic. where we again do a detailed epilepsy phenotyping. We again review all the investigations patient has had till date, and we make sure patient doesn't need to be discussed in a multidisciplinary meeting for anything more potentially curative resective surgeries. Once the patient is deemed a good VNS candidate, then we make referrals to neurosurgery. We usually perform a baseline neurodevelopmental or psychological assessment. We refer to sleep clinic for a clinical evaluation and also possibly baseline sleep study. We perform baseline ECG just to make sure they don't have any abnormal cardiac rhythm abnormalities. And after that stage, since we have limitation number of devices we can implant in a year, so after usually a wait list of around 6 to 9 months, patient get a VNS implant. On the day of VNS implant, one of our team members will engage with the family for teaching and education, and also will do a scheduled pre-programming for the patient. And subsequently, the patient is followed in our VNS clinic, usually every 2 to 3 months, depending on the need and requirement. So to quickly summarize, I think proper selection of patients is important for VNS. Make sure more potentially curative surgeries cannot be offered to this patient. VNS frequently leads to meaningful improvement in seizure frequency and severity. Improvements in quality of life and reduced mortality risk is often observed. Side effects in general are usually mild and easily manageable. Always be aware of the MRI safety issues with VNS or other neuromodulation strategies. Thank you so much for very patient listening. I'm really honored to be working with an amazing team here at SickKids. Big thanks to Caitlin and Lindsay, who are the current pillars of our VNS program. Ivana and Tina, who built this program in the past and still are very actively involved with us socially. And to our bestest neurosurgeons, Dr. Ratka, George, and Isha. Thank you so much. Happy to take in questions.
Thank you so much for the excellent talk, Dr. Jain. There are a few questions in the chat, so I'll read them to you. Priyanka asks, have rapid VNS escalation protocols been used in young children/infants with DEEs?
So, sorry, if I got the question right, the youngest age she wants to know?
I was wondering if Priyanka wants to know if rapid VNS escalation protocols have been used in children or infants with developmental and epileptic encephalopathies.
So we do have used these rapid up titration protocols, increasing stimulation parameters every 4 to 7 days, depending on the urgency. But I would say we haven't used VNS in patients younger than, I would say, 20, 24 months of age. So I don't have experience with the infants. But in older children, definitely, if there's an urgency, we can quickly up titrate these VNS settings based on tolerability.
Thank you. Wajid Alataibi asks, thank you for the very comprehensive review. Do you have a surveillance for sleep disorders or cardiac arrhythmia before VNSs are implanted? So do you screen for sleep disorders or cardiac arrhythmia before the VNS is implanted?
So we do refer our patients to the sleep clinic for the initial clinical evaluation. And since most of our patients are very complex, they have severe DE, significant neurological comorbidities, most of them end up getting a baseline sleep study before the VNS implant. And right now in a research setting, they are also doing a post-VNS sleep study as well in some of these patients. So definitely a strong screening protocol for the sleep part. For ECG, obviously, we do take a medical history, but besides that, I think we in general use just a baseline ECG for quick screening, unless there are any red flags in the past medical history.
I will use my prerogative as the moderator of the questions to comment that in many adult centers, including ours, we do a pre and post sleep study as well. We don't always refer to sleep clinic because, of course, there's sometimes a rate limiting factor with delays to sleep clinic, but definitely a sleep study before and after, which can be challenging because in adult patients, you're only permitted a single sleep study in a lifetime. So that can be hard to, yeah, so it's a bit different in adults, but we figure it out. So the next question is, sorry, we're bouncing around a little bit. According to your experiences, which candidates are unsuccessful with VNS? So for example, certain epilepsy syndromes, generalized epilepsies, etc.
Yeah, so I think that was one of the slides. We really do not know who will respond and who will not respond. based on the clinical variables, but I think a lot of these network-based connectivity markers are definitely coming up in a big way, and hopefully these will help us in future in selecting these candidates. But right now, uh, no epilepsy syndrome, no seizure type, no etiology, I think predicts who will be good responders or who will be non-responders, unfortunately.
Chuk Him Andy had a question. Do all patients deemed VNS candidates get a sleep study referral at Sick Kids? And I think you answered that yes, they do.
Yeah.
Sleep study. Luc Menard asks, how long does it usually take to find the optimal stimulation settings?
Yeah, so I would say when we start the initial scheduled programming, we usually program them to 1 milliampere, and we usually call them in clinic in 2 to 3 months. And as an initial protocol, we try to reach at least 1.75 milliamp of current as an initial target. But again, based on tolerability, we can further optimize the output current or the duty cycle. But again, there's no one optimum parameter settings. But in general, 1.75 to 2.25 milliamp is the sweet spot for the output currents. In duty cycles, it's not known. Some studies have shown 17% as the sweet spot, but again, these are based on very limited kind of data. So every patient is different. We need to titrate these settings and see the response.
Thank you. Jacob asks and says, excellent presentation. I agree. Do you know anything about future LivaNova or other company models in the pipeline in America, China, or elsewhere?
So I think China already has their new models, which I heard they had even a booth at the International Epilepsy Congress. And I hear that they have many more features in addition to the LivaNova device that we use in North America and Europe. But I don't have any personal experience with that. But definitely there are more different kinds of devices which are in pipeline with different features. We have these transcutaneous auricular VNSs, microburst VNS coming up. So multiple stimulation paradigms are being explored. And I'm sure in near future we'll have many more options. But right now, I think besides LivaNova, definitely there's a Chinese device, which is very widely used in that part of the world.
Thank you. And Lauren asks, do you think that the reported response to VNS in fires could be related to the natural course of seizure improvement weeks after the onset of fires?
Absolutely. I think that is a very relevant question. I think in most of the studies, the latency to get VNS was 80 to 90 days. So definitely we need a better quality prospective data to answer that question. Definitely natural history of fires can play a role with whatever efficacy that we are seeing in with VNS in these patients, for sure. But I think one of the other prospective studies that I quoted, which was more of a comparative study, in that study, definitely they showed that patients who got VNS had a shorter duration of status post-VNS as compared to patients who did not get VNS. So some signal of efficacy, but definitely we need much better prospective studies in this field.
To add to that question, I'm just curious, was there an improvement in or evidence of improvement in cognitive function or quality of life if a patient with fires had received VNS, or just seizure improvement?
These studies only reported very short-term outcomes, so they did not explore more longer-term quality of improvements.
Thank you. Chantal has a question. I recognize that you had limited time to review the logistics of VNS programming. But given recent case series highlighting that ultra-rapid duty cycles are often well tolerated and can markedly improve VNS efficacy in initial VNS non-responders, how do you think we should define a VNS failure before progressing to other neuromodulatory options such as DBS? Chantal has recently learned in her practice that duty cycles as high as 44% may be well tolerated in outpatients and substantially more effective than traditional duty cycles of 10 to 16%.
Thanks for bringing that up. I think I did encounter that recent paper from US, one of the US centers, where they used ultra rapid duty cycles and reported responder rate of more than 90%. I think in our situation, we do use rapid cycling where the off time is less than 1.1 minute. We haven't used a lot of ultra rapid cycling, so we don't have a personal experience. But I'll just add that with obviously these ultra rapid duty cycles and all the other more aggressive strategies. The battery life is always a concern, so it's something to be kept in mind. But I'm definitely really surprised by the data which came from this US center, and we'll try to see what our personal experience is. I'm not sure if someone in the audience had a better experience with ultra rapid QT cycles. But personally, we haven't used that too much at our center.
I think at our center, we're always mindful of, again, battery life and also side effects, because some patients just don't tolerate the rapid up titration. So, but yeah, but I've had the same experience as Chantal myself in adults, again, not in pediatrics, that it can be very effective. I'll address one more question just because we're just at time. So Shukim and Andy asks, has anyone looked at CSF biomarkers, for example, neurotransmitters for VNS responsiveness? Thank you.
I don't think I'm aware of a CSF neurotransmitter study, but definitely people have looked at the blood cytokine levels. But I'm not aware of a study which has looked at CSF biomarkers. Might be some ethical challenges as well to do lumbar punctures in these patients just for research. But good question, but I don't think there's a study.
Thank you so much. I think we're at time, so I think we're done with questions. So I'll hand it back over to Robin.
Thanks, Lisa. And thank you again, Puneet, for joining us today and sharing your clinical and research expertise in VNS. A really excellent talk. And I think we all learned something, and amazing question and answer period after. So we'll see everybody in March for another CETN CLE rounds. And I hope everybody has a great weekend. And thank you again, Puneet, for joining us.
Thanks so much for the invitation. Thank you. Bye.
Bye, everyone.
Thank you.